Good afternoon, everyone. Good afternoon, dear colleagues. Welcome to this first ESNM webinar. It is the first webinar of a series of three. The next two webinars will be in, let me check, in September and November or December. It's my pleasure to co-chair this webinar with Ram Dikman from Israel. This webinar is dedicated to dysphagia, and as you know, we have here with us some of the colleagues, experts, who have built the guidelines on dysphagia. These guidelines were published by the UEG. So we will have mainly experts from Italy and Israel. And we will see successively some epidemiological aspects, some diagnostic aspects, and then some therapeutic aspect. And Luisa from Italy has prepared for us a very interesting case that will stimulate the discussion. So our first speaker is Andrea Pasta from Italy, and he will talk about the epidemiology and diagnosis of or the definition of dysphagia. Andrea, you have the floor.
Okay, thank you. I'm sharing the presentation. Okay. So, thank you for the presentation. Good afternoon, everyone, and thank you for joining this webinar, of course. And I would also like to thank the Scientific Committee of the ESNM for the kind invitation. So today I would talk about dysphagia, and I will give you a particular focus on its definition and epidemiology. And yes, we all know that dysphagia is not only symptoms, it can be the sign of different diseases, and it can also have some important complication, and it can impact the quality of life of our patients in so many ways. So it is important to focus, my conflict of interest, it is important to focus on the correct definition. And we know that over the last decades, the definition of dysphagia has changed a lot. And at the very, very beginning, the definition it was very simple and was defined as difficulty in swallowing. And of course, this definition was correct, but it was not complete. Because we know that the swallowing is a complex process that involves mouth and pharynx and esophagus, upper and lower esophageal sphincter, as well as the nervous system and muscles. So later this definition was updated, and the World Gastroenterology Organization reported that the definition of dysphagia was as a dysfunction of any part of the swallowing apparatus, and this included also the oral phase, the pharyngeal phase, and esophageal phase. And more recently, this definition was updated with the white paper and the Danish Delphi consensus with the inclusion of the effect of dysphagia on the fluid and food intake, so taking into account malnutrition, the risk of malnutrition. So, coming to the recently published guidelines, this definition was updated with a more modern and structured view of this important problem. First of all, the definition was divided into oropharyngeal dysphagia and esophageal dysphagia. And overall, the dysphagia was defined as a swallowing dysfunction. Coming to oropharyngeal dysphagia, it was defined as an impaired safe and effective transfer of the bolus from the mouth through the pharynx and then into the esophagus. And as we can see, there are two keywords in this definition, safe and effective. And we know that safety means avoiding aspiration, choking, and overall the food entering the airways. And at the same time, the swallow should be effective. In this case, it means that it is enough for patients for maintaining adequate nutrition and fluid intake. On the other hand, the definition of esophageal dysphagia was a difficulty in swallowing, which was perceived retroexternally and involved the esophagus and the lower esophageal sphincter, and it can be caused by different causes, anatomical, mechanical, inflammatory, or functional abnormalities. And we should consider that this distinction is very important as the following diagnostic and therapeutical workup is different between the two entities. At the beginning of the evaluation, and it is important in the definition of the problem, we should consider that history taking is important and is recommended by the guidelines, but overall is insufficient for distinguish between oropharyngeal and esophageal dysphagia. Of course, it's important to evaluate symptom onset, the bolus involved, the bolus type involved, the perceived localization, as well as the presence of associated symptoms such as choking and coke and others. But the key message of this part of definition is that the initial history taking, the initial symptoms evaluation is not sufficient to differentiate the two forms, but it can be useful for orientate the following test and treatment management. Talking about epidemiology, the prevalence of dysphagia, we should consider that dysphagia is a common symptom, and its prevalence changes according to the population we are studying, as well as the diagnostic tool, the diagnostic method we are using. We can say that overall in general population, the prevalence is estimated between the 10 and 20%. But in some high-risk groups, such as older people, patients with some neurological condition, or people with cancer of the head and neck district, this prevalence may be higher and higher. And it also changed, another important point is that the diagnostic tools may influence this prevalence, and we know that using questionnaires we can identify fewer cases than using physical examination and of course instrumental tests. And also the prevalence analyzed in the study is influenced by these evaluations. To note, we have, according to the literature available, not enough data to explore the prevalence of esophageal dysphagia as a separate entity. Coming to the prevalence of oropharyngeal dysphagia in specific, we can see that in this important systematic review with meta-analysis, the prevalence is higher in patients with dementia, and it reached around 70%. And it is also higher in in post-stroke patients, which are involved in which in these cases the prevalence is about 50%, and it is also higher in older people aged above 60 years. And when we talk in the epidemiology of the esophageal dysphagia, we can focus on esophageal motor disorder. And in this study that I'm reporting, this is a study of our university, a retrospective study, and we showed that in older patients, normal esophageal motility was less common than in younger individuals. And at the same time, the indication for performing HRM is highly influenced by the age of patients. And we observed that in older patients, the main indication for HRM test was dysphagia. In contrast, in younger people, the indication was the GERD spectrum. We also observed that some esophageal motility disorders were more common in older people, such as AGJ outflow obstruction, as well as hypercontractile esophagus and some types of achalasia. Our study was later confirmed by an international court presented by Amir in the last ESNM meeting in London. And he confirmed that in older people, high-resolution manometry is more often performed for dysphagia, while in younger people, it may more often perform for the GAD spectrum, for the GAD evaluation. We also observed with this study that the diagnostic yield increased with age. And I can say that, in other words, the probability of finding a motility disorder is higher in older patients. And we also observed that not only any motility disorder, the prevalence of any motility disorder was higher in older people, but also the prevalence of the motility disorder that involved the AGJ, the esophagogastric junction. We should consider that dysphagia is not only a clinical problem, it also has an important economic and social impact. And as we can see from different papers in the literature, patients with dysphagia often have a longer hospital stays. And overall, in some studies, we observed that these hospital stays is longer of about 3 to 4 days in patients with dysphagia. And this longer hospital stay is associated with a higher cost in terms of healthcare resources. And in some population, for example, patients with Parkinson or patients after stroke, this economic burden is particularly relevant. So overall, we can say that it's important to detect early this problem, because it is not only a clinical issue, but it can also have an important impact on our healthcare systems. Go straight to my conclusion. I can say that dysphagia required a structured clinical approach as embodied in the definition of the dysphagia itself. A careful history taking, careful history evaluation of the patient at the beginning is very important and can guide the following management in terms of diagnosis and therapies. And we should consider that some high-risk patients should be screened in a proactive way. And I can encourage the involvement of a multidisciplinary care to improve safety, nutrition, and the overall quality of life of our patient. And thank you for your attention.
Thank you, Andrea. May I ask you just a quick question? Not so easy. I'm sorry for that. Do you have any tips and tricks about making the difference between oropharyngeal dysphagia and esophageal dysphagia?
Okay,
It,
I
it,
agree with you that this is a very tricky question. Yes, of course, we can use some tests in the setting of clinical practice. We know that there are some questionnaires, some important question, and it is important to note that sometimes patients refer a sensation that for the neurological apparatus of the esophagus, symptoms may be reported retrosternally, but may be related to an upper part of this apparatus, or sometimes it is tricky to understand what the patients may are reporting to us. So I think that we should rely on the clinician opinion, and some questionnaires can hide, some tools can hide. And at the first evaluation, we should consider to prescribe or the esophageal management, the management for esophageal dysphagia, which is at the first evaluation the upper endoscopy, or to prefer to carry out some tests for the oropharyngeal one.
to say, in other words, is that a patient presenting with upper dysphagia or swallowing disorder may have an esophageal dysphagia, in fact.
Yes, the problem is that sometimes And I think that the statement of the guideline uh, is very important in this field because sometimes symptoms are tricky. Most of time,
Okay.
symptoms may be tricky.
So now we move to the clinical case prepared by Luisa from Italy. A very interesting case. Luisa, can you share
Uh,
your slides?
yes, of course. I
Thank
would
you.
also like to thank Professor Zerbib, Professor Dikman, and the ESNM for inviting me and for the kind invitation. And I feel really privileged to be able to present the case of KG, which is a 25-year-old man, a student, lean, with a BMI of 18.9, physically active and an occasional e-cigarette user. He has an atopic background with bronchial asthma, a positive maternal history for atopy, and his esophageal symptoms started in September 2020. The onset was indeed insidious. He began noting intermittent solid food dysphagia, but he managed himself through drinking water during every meal. And through 2021, symptoms but worsened. And he had more episodes. And by September 2021, when he was referred for endoscopy, his daily intake was impaired. And was when it finally came to our attention and we performed a gastroscopy, which showed furrows, edema, and exudates, and esophageal biopsies confirmed picosynophilic count up to 75 per HPF and eosinophilic microabscesses, as well as lamina propria fibrosis. So very easy diagnosis of EOE was made, and the patient was started on PPIs and topical steroids. And so now it's just like a textbook case, but after 3 months of therapy, he was admitted to our unit for complete dysphagia. He was unable to swallow both solids and saliva for 2 days, and he reported no symptom improvement. Though to be fair, his adherence was kind of poor. We of course performed a new gastroscopy, which showed the persistence of furrows, but at histology there were no eosinophils, only a minimal lymphocytic exocytosis of the squamous epithelial lining of the esophagus. And that was when we first reported the disconnect between his symptoms, which were very, very severe, and objective evidence, which showed endoscopic remission and histologic remission. So before Professor Mari's talk, I would like to leave the audience with a question. In a patient whose EOE looks histologically controlled, but whose dysphagia is worse than ever, what would you do next? Would you repeat the gastroscopy after swapping treatment, maybe a biologic therapy? Would you perform the varicol, high resolution manometry, or maybe an endoflip? So this was the first case.
Thank you. So to summarize, your patient has a EOE. He has a quite classic phenotype with a young man with atopy, and as far as I could see, typical features of EOE on endoscopy and histology.
Yes. Yes.
He is in histological remission, but not in clinical remission. I'm correct?
Correct.
Okay.
Yes.
Thank you.
You summarized
Suspense.
it very well.
Let's
You
let's
can
wait.
you can now answer the question, maybe.
Okay. So now we are going to listen to Amir Mari, who was the coordinator of these guidelines on dysphagia. Amir, you have the floor. You can share your slide. Thank you.
Okay, thank you very much, Frank, the RAM and the ESNM Scientific Committee for having me for this nice talk. All right, so I will rely mainly on the guidelines that we have worked on together for many months and published last year. The background by Francisco was very helpful to me, so I will just go through and talk mainly about the diagnostics of the diagnostic approach to dysphagia. And basically, recent years have witnessed a lot of advances in diagnostic motility technologies, but also in some guidelines. We have the high resolution manometry with the Chicago 4 classification, the barium swallow techniques. Barium is quite old, but some techniques like the time barium swallow is quite new. We have the endoflip, and there are also some advances in the field of oropharyngeal dysphagia with the FEAS and some imaging studies and some classifications like the Leuven classification. So I will go very briefly on approach to dysphagia. History taking is the first initial part of approaching dysphagia patients. And it's very important to start to understand from the patient if his dysphagia is high dysphagia or oropharyngeal dysphagia, or either this is an esophageal or low dysphagia. This is extremely important, and it has reached a consensus between the experts, but history is not sufficient to differentiate between oropharyngeal and esophageal dysphagia, since esophageal pathologies like achalasia could have a involvement of oropharyngeal dysphagia in about 30% of cases. And this also has been shown by our group in Nazareth from our achalasia cohort. It's very interesting also to say that sometimes achalasia patients have only oropharyngeal dysphagia without esophageal dysphagia in very minority of cases, about 5–10%, but it's very interesting. So anamnesis and history taking is good, but it's not sufficient. Then when we approached a dysphagia patient, we have to do endoscopy. This is very important to start with endoscopy, upper GI endoscopy, because we need to evaluate the anatomy and the mucosa of the esophagus and the lower esophageal junction, the LES. It's also very important to look for a obstruction or achalasia findings in endoscopy that might be found. And now, in the last 2 decades, with the era of the AUE, we can also look for AUE endoscopic findings, but also it's very important to take enough biopsies to look for AUE. So endoscopy is the first step of the evaluation. Then we move further. If we don't find explanation for the dysphagia by endoscopy and biopsy, the next step and the gold standard way to assess patients' dysphagia, to assess the esophageal motility, the lower esophageal sphincter function, and probably also the upper esophageal sphincter function, as we have learned recently from the Leuven group, we need to move to high resolution manometry. It's very strong recommendation, which has reached a very high agreement between experts. Endoscopy, manometry. What we can learn from manometry. So basically, the manometry will be learned or looked according to the Chicago 4 classification. And first, we look at the esophagogastric junction. We need to see if there is a obstruction at the esophagogastric junction, and this is always pathological. It could be any type of achalasia, but also it might be esophagogastric junction outflow obstruction when there is obstruction with normal esophageal motility. Generally, disorder of the esophagogastric junctions are pathological, looked as major disorders and symptomatic. Second thing, we can assess the esophageal motility by the high resolution manometry. We can find major motility disorders like distal esophageal spasm or hypercontractile esophagus, or absent contractility. Or sometimes we can find minor pathologies or disorders like ineffective esophageal motility, which the importance of this finding is not very clear. In recent years, maybe in the last decade, the EndoFlip, which is a kind of a new technology, has gained a lot of publicity, and mainly we use it as adjunctive or additive technology when we don't have a specific or accurate or adequate diagnosis by endoscopy and high-resolution manometry. EndoFlip is done under sedation, and it assesses the distensibility of the lower esophageal sphincter. And recently, we also have learned that we can assess panimetry, which also can give some clues about the esophageal motility. It also has high level of agreement between experts to be used, mainly in cases where we don't have adequate diagnosis in symptomatic patients by high resolution esophageal manometry, or if we want to learn more about the clinical relevance of esophagogastric junction outflow obstruction. Last modality maybe for the esophageal assessment is the esophagogram, or the timed barium swallow, where we ask patients to drink barium, and we can make films of the barium after 1, 2, and 5 minutes, and we can look at the anatomy of the esophagus and the esophagogastric junction. But more important, we can look at the flow or the clearance of the fluid at the esophagogastric junction level. So, if I want to summarize all of the things that I have said so far, and these are not many things, when we want to approach patients with dysphagia, first we have to understand if this dysphagia is esophageal or oropharyngeal, if it's upper or lower. As a gastroenterologist, we mainly deal with patients with esophageal dysphagia. Patients with oropharyngeal dysphagia may be followed by a more multidisciplinary team that mainly includes ENT doctor, neurologist, speech therapist, and sometimes also gastroenterologist. So for cases with esophageal dysphagia, we start with upper endoscopy, and we take biopsies. So if there is any abnormality diagnosed, so we continue with the diagnosis and we give treatment. If we don't find any diagnosis in endoscopy and biopsy, so we move to high resolution manometry. And if we have any pathologies identified, like achalasia, outflow obstruction, jackhammer, hypercontractile, distal esophageal spasm, this kind of major motility disorders that explain the dysphagia, so we move to a specific therapy. But if we don't have any of those, we stop here in this point and we ask the patient and ourselves how much dysphagia this patient has. Probably, maybe this might be sometimes symptoms of CHAD. So also we need to think if there are clues of CHAD to do pH monitoring, and if not, it's only dysphagia without other symptoms that could be related to GERD, we continue to more adjunctive tests like barium swallow or EndoFlip. Again, if we have any specific pathology or abnormality, so we treat accordingly, but if not, we need to think about extra luminal compression, especially in patients with the risk factors for malignancy like smokers, old age, male. So maybe we need to do for them a CT scan or MRI. If we have done all of these tests and we don't find any pathology, probably we can consider these cases as functional esophageal dysphagia, and we try to treat them as a functional disorder with neuromodulators or SSRIs, but preferably these patients need to be followed in a specific expert clinic. For cases where oropharyngeal dysphagia is the dominant one, as I have already mentioned, these cases need to be followed in swallowing disorder units where ENT doctors, maybe neurologists, and a speech therapist who is dedicated to swallowing disorders. This is the place for these patients to be followed. But we start with them with clinical swallowing evaluations by an ENT doctor and speech therapist. Generally, this is not enough, it's not adequate, and in most cases, we need to move further with the fibroendoscopic evaluation of swallowing piece or video fluoroscopy evaluation for swallowing, or probably pharyngeal manometry according to the looping consensus when this is feasible and when we have the expert who can do the manometry. Probably the FEES is the most important and relevant test to do in these cases because it also can predict therapy. So patients, we can know which food to give them and in which consistency. So it might have some therapeutic applications. That's why it's the more recommended one. Generally and preferably, if we have the two options to do FEES and video fluoroscopy, it would be better. Okay. Also, in cases of oropharyngeal dysphagia, if we don't have pathologies found on the first evaluation, then we move to the second set of tests, adjunctive complementary tests like more endoscopy, barium, manometry, end of lip, and other tests, because I have said that sometimes history taking is not accurate and people can have only oropharyngeal dysphagia, but their main major problem is basically esophageal. So if I summarize so far, dysphagia is a prevalent symptom having consequences and impacts quality of life with a global burden, economic burden. We have to start with this classification of swallowing, which is oropharyngeal versus esophageal. The role of endoscopy, high resolution manometry, end of lip, barium swallow, and other imaging tests in evaluating esophageal dysphagia has reached overall very strong agreements in our guideline paper. The role of video fluoroscopy swallow alongside this fiber endoscopic evaluation of swallowing were considered as the methods of choice when we approach instrumental assessment of oropharyngeal dysphagia. Thank you very much.
Thank you, Amir. I forgot to mention that you can ask questions if you look at the bottom of your screen. You can unshare your screen now, Amir. Thank you. At the bottom of your screen, you have this Q&A that where you can click and ask your question. We have a question about manometry and the evaluation of upper esophageal sphincter. What do you think about this technique? There is a question about water-based manometry versus solid state catheter. What is your opinion? Did the guidelines made any statement about this?
All right, so regarding the first question about the role of manometry in evaluating upper esophageal sphincter, this is a very important question. We have just discussed this in a local meeting for 2 days, and there is a very important big consensus. It's called the Leuven consensus, that have been published, I think, last year or before 2 years, about what we need to know about the role of manometry in assessing upper esophageal sphincter. There are some normal values there, pathologies, and important classifications. It looks a bit similar maybe to the Chicago classification of the lower esophageal sphincter. It's not very mature yet, but I think it will be developing for. The main people who is dealing with this, I think these are ENT doctors and maybe speech therapists. As a gastroenterologist myself, I have to say that I don't have enough qualification to look at the upper esophageal sphincter according to Leuven consensus. I just can't say if it's opening or not, but I think that the role of manometry, learning the upper sphincter, is evolving, and I think soon, in the coming few years, we also need to learn how to
Thank you,
look
Amir.
at
We have to move on. Thank you very much. So, if I want to summarize, because there are some questions about this, for the time being, there is no evidence that manometry is superior to video fluoroscopy for the evaluation of oropharyngeal dysphagia. Can we summarize like this?
Well, so far, the most important techniques are video fluoroscopy and fiber optic evaluation.
Okay.
The role of manometry is inferior to both of these, but maybe it's evolving now.
Thank you. So, Luisa, we are waiting for your case.
You already have a little bit of insight. All right, I'm sharing my screen now. Okay. Hope you can all see. So welcome back. Let me pick up where we left off. To recap, KG is an atopic 25-year-old with confirmed EoE. He started combined therapy with PPI and steroids, but he was admitted in our hospital because he had complete dysphagia. However, paradoxically, endoscopic and histology showed picture of remission. So this mismatch is what drove the next evaluations, which were barium solo, which showed dilated thoracic esophagus, outflow obstruction at the level of the EJJ, and the cardia measured with radiologically was of 4 millimeters. We, of course, then performed manometry. This is his manometry. As you can see from the swallows, there is no relaxation of the lower esophageal sphincter. The median IRB was 27.3. And after each swallow, there is complete absence of peristalsis, no significant pressurization, and no premature contractions, leading to a diagnosis of achalasia type 1. So we found ourselves looking at two diseases in the same esophagus. To support EoE, we had the atopic background, typical endoscopic findings, and intraepithelial eosinophils way beyond 15 per HPF, as we had found 75 per HPF on the first endoscopy. And on the achalasia side, we had dilated thoracic esophagus on barium swallow, type 1 achalasia pattern on HRM, and severe dysphagia unresponsive to EoE therapy. So I would like to leave the audience now with a second question. When you have two diseases in one esophagus, which compartment do you treat first? Would you treat both? How would you treat them? Please hold this spot for Professor Savarino's talk.
Thank you, Luisa. Very intriguing case, but we have some cases like this. So I'm very happy to welcome Edoardo Savarino from Padua, and Edoardo will help us to manage these patients with dysphagia. Edoardo, you have the floor.
Yeah, thank you, Frank, and thanks for all the people being attending this nice webinar. And indeed, the case was quite challenging at the beginning, but I will, of course, cover all the aspects, all the full spectrum of dysphagia, and then we will discuss a little bit about how to treat these particular cases. You know that we published last year the guidelines, and so I will use these guidelines just to cover all the aspects of dysphagia for our audience. I split my presentation about esophageal dysphagia and oropharyngeal dysphagia. For esophageal dysphagia, you know the treatment algorithm that we developed in these guidelines, in which this separates dysphagia according to the etiology, so functional dysphagia, other specific diseases, and diagnosis of motility disorder. There is a mistake there. And for motility disorder, I will start with ineffective esophageal motility. You know that there is no clearly effective medical treatment able to improve motor function in patients with ineffective motility disorder. The management of this patient usually belongs to the clinical scenario we face front. These are the recommendations provided by the guidelines. The management should focus on treating symptoms rather than motor findings, particularly in GERD patients. So PPI therapy is usually the first option that we use in clinical practice. There are many prokinetic agents, or I mean, we call them prokinetic, but the effect on motility of the esophageal motility is a little bit unexplored and undemonstrated. But we have metoclopramide and domperidone, which did not show in clinical in trial to be effective at improving esophageal motility activity. We have macrolide antibiotics like erythromycin and azithromycin, which provided some evidence, particularly in gastroesophageal reflux disease patients. And we have prucalopride, which has been shown in one study to have some promising effect, particularly again in gastroesophageal reflux disease patients with ineffective esophageal motility. Moving to hypercontraction, esophageal hypercontraction or spasm. Indeed, in this patient, we need a multifaceted approach. The UAG ESNM suggests the use of PPI, calcium channel blocker nitrates, phosphodiesterase type 5 inhibitors, and some medication to treat more the symptoms than the motility pattern, like antidepressant or peppermint oil. There are some evidence. Unfortunately, the evidence is not so strong to recommend them in every cases, but you know that also in a case of hypercontraction or spasm, we have as first-line treatment proton pump inhibitors, particularly in case of overlapping GERD symptoms, then calcium channel blocker nitrates and phosphodiesterase inhibitors. There are more clinical case reports or case series than prospective randomized control trial to demonstrate the efficacy of these drugs in this type of condition. Then we know that neuromodulators is something that we use in clinical practice when we do not know how to treat the condition and how to resolve the symptomatology. And in some cases, peppermint oil or antimuscarinic drugs may be effective in treating the esophageal spasm. In the case of hypercontratile esophagus of Jacquemer, there are some evidence showing that if we do not do anything, there is anyway a good probability of having improvement of esophageal hypercontractility, like Jacquemer. On the other hand, we have some data regarding the use of botulinum toxin injection. A randomized control trial made in France did not demonstrate a significant improvement in terms of symptomatology, whereas a randomized control trial done in Belgium from Tim Van Utzel show some efficacy, clinical efficacy, and also reduction of esophageal wave amplitude as demonstrated by high-resolution manometry. There are also some evidence regarding the use of POEM, peroral endoscopic myotomy, and surgical myotomy. Some case series collected in a systematic review showing a benefit for patient reporting the esophageal chest pain and dysphagia, and also a study done in Padua with surgical myotomy, again showing some efficacy, but I would be very, very careful in selecting this two type of approach in jackhammer esophagus. As to EGJ outflow obstruction, as we heard from Amir Mari, this is a challenging high-resolution manometry pattern, and so we have to be really sure that we are facing front a case of esophageal obstruction. There are 4 types of EGJ-OO to guide treatment: a mechanical obstruction, medication-related, and the case of the idiopathic non-relaxing lower esophageal sphincter. In general, we know that most of these cases may cannot be treated because during time we have a sort of auto-resolution of EGJ outflow obstruction in up to 70% of the cases. When it is necessary to treat these cases, we have different options, including endoscopic and surgical intervention. In case of structural EGJ outflow obstruction, when we have stricture, of course, dilation is the best option. And in case of functional EGJ outflow obstruction, as proven by high-resolution manometry, esophagogram, or endoflip, we may use again interventional endoscopy, including POEM, to treat these patients. In patients with functional dysphagia, finally, antidepressant or neuromodulators are a good option to treat this condition. Also, in this case, there is not a big evidence in medical literature, but we know that pain modulatory effect due to the use of neuromodulators can be effective in treating this patient. Also, in Rome 4 and in Rome 5, there is a suggestion to use empiric dilation with endoscopy to treat this condition. A small brief for the treatment of esophageal achalasia since the case treated this condition. These are the guidelines published in 2020 on the UAG journal. Again, a collaboration guidelines made by UAG and ESNM. You see that POEM, laparoscopic LR myotomy, and pneumatic dilation are all good therapeutic option for treating achalasia. And for eosinophilic esophagitis, there is a guidelines published in 2019, which is quite old. The next one will be published this year, and the next year for the therapeutic management of this condition. So I use the one we published on digestive liver disease 2024. In Italy, you see PPI, topical corticosteroid dietary therapy, and monoclonal antibodies, all as first-line treatment for eosinophilic esophagitis. For oropharyngeal dysphagia, this is a little bit more complex and challenging, and is, of course, something that should be delivered to the patient by specialized physician. You see again that there is a different setting where we can use different type of approach. The UAG and ESNM consider the use of swallow therapy for this condition in order to improve swallowing mechanics, reduce symptoms, and enhance quality of life. There are different methods which are applied in clinical practice with some randomized control trial to prove their efficacy. Pharyngeal electrical stimulation, respiratory muscle strength training, and repetitive transcranial magnetic stimulation are the ones which are used more commonly in clinical practice. I would like to focus a little bit also on laryngeal recalibration therapy, which is quite effective also on treating extraesophageal GERD-related symptoms. There is also the option of using surgical treatment or endoscopic treatment. This, of course, particularly in case of alteration of anatomy, like in case of Zenker's diverticulum and cricopharyngeal bar. Also for oropharyngeal dysphagia, there are a number of systematic reviews with or without meta-analysis providing some evidence on the use of neuromodulator therapy in treating dysphagia in these patients. I would like to thank you also, all the members who collaborated for these guidelines, and you see here the list, and I'm open for questions.
Thank you, Edoardo. We are running a little bit late. There is one question about the treatment of functional dysphagia and hypocontractile esophageal, or IEM. What you say that there is no real efficient treatment for that.
In fact, esophageal motility indeed is something really, really complex. Also, because we don't know really if, in effect, esophageal motility is the cause of symptomatology. But we use usually prokinetics, and if they are not effective, usually we move to neuromodulator therapy, which include amitriptyline, trazodone, and citalopram.
It is quite rare in my practice that the pure IEM is responsible for severe dysphagia. Usually patients have mainly reflux or for example, if you look at patients with scleroderma, there is a completely aperistaltic esophagus. They complain very little bit of dysphagia. They have a very mild dysphagia usually, and they mainly complain about reflux. So I think that be careful before saying that IEM is the cause of a severe dysphagia. And the main trick is that sometimes you have type 1 achalasia with normal IRP. And you have to look very much, if the dysphagia is severe, it is not IEM, which is responsible for, there is something else, peptic stricture, achalasia, or something else. So Luisa, we can move now and finish with your very interesting case, please.
Yes.
Thank you, Edo.
My pleasure.
Okay, sharing my screen now. Okay, so welcome back for the last segment. To orient us quickly, KG had received the diagnosis of EOE in September 2021, and he also received the diagnosis of type 1 achalasia in January 2022. So we had to select a therapeutic plan to address both. And what we did during the first hospital stay was in January 2022 was a pneumatic dilation with a 30 millimeter balloon under this sedation with no perforation and no complication. On a post-dilation swallow, the cardiac caliber measured radiologically had already improved, and by 4 weeks it was in clinical remission. In July 2022, since adherence was still an issue, we switched to budesonide or a dispersible tablet that had then become available in Italy. And he also maintained endoscopic and histologic remission with this therapy. And by July 2024, normal oral intake was restored. And the proof of that, perhaps the most tangible and convincing evidence was that he had gained 18 kilos in 3 years, going from 60 kilos to 78 kilos. So unfortunately, in December 2024, occasional dysphagia for solid head returned, and in just 1 to 2 months time, he had daily symptoms, and he had just 1 episode of frank food impaction. So what we did was repeat endoscopy, which revealed a markedly dilated tortuous esophagus with pale mucosa and exudates, but no eosinophils at histology again. So we did a new barium swallow, which showed an esophagus dilated to 5 centimeters and retention to the mid third. So where do we go from here for this motor disease? Would you repeat the pneumatic dilation, perform a endoscopic myotomy or surgical myotomy? These were the three cases, the three options on the table, and this is where the case became multidisciplinary, which in our hospitals mean having to deal with Professor Savarino on the gastroenterology side and Professor Salvador on the surgical side. But the decision actually belonged to the patient. So after a detailed shared decision making with this very difficult patient, KG arrived at his choice through a process of successive exclusion. So he excluded to repeat pneumatic dilation because he had already undergone one and he was unconvinced of his long-term durability. The second exclusion was a surgical therapy because we couldn't assure him that he would be free from the medication and he wasn't comfortable with this procedure. So what remained by elimination was the middle path, which was peroral endoscopic myotomy. I will show you very briefly the procedure, which involves mucosal injection. And the second step is the mucosal incision to enter the submucosal space, as you can see. It's a posterior fibroclavic incision, and then the submucosal tunneling is the mucosa above and the muscle below. Finally, the myotomy, the cutting of the muscle across the EGJ inside the tunnel. And of course, the mucosal closure, which you can see here with endoscopic clips. So as of May 2026, that is today, the patient is still on track, continuing his budesonide, is on PPIs, SNO dysphagia, and has a stable weight. I wanted to close with a broader scene because cases like KG sit at the intersection of two diseases whose relationship is ambiguous. So I found cases in the literature where treating the EOE reversed the achalasia pattern at high resolution manometer, which I found very interesting. And also some cases of eosinophilia in the esophagus resolved after treating achalasia, probably, of course, of stasis, but also cases like KG where you can see the two diseases having parallel courses and resolving one disease did not cure the other. So thank you very much for the attention, and questions and comments are very welcome.
Thank you very much, Luisa. It is my vote is number 3. I think that your patient had obviously both disorders. I don't know what the other experts think, but he has typical features of EOE and typical features of achalasia. They are two quite common or non-exceptional disorders, and they may coexist in one patient, I would say. But the most important is that your patient is doing well and you manage it very well.
I think the only way of proving it completely would be to take off his EOE medication and do a gastroscopy.
Absolutely.
That is the only way, but I think since it's a very easy therapy and we had those very typical EOE endoscopic features at the first endoscopy, I think we're not going to do that, but I think that is the only way we could prove he has both diseases by now.
Okay, I don't see any more questions, so I would like to thank all the experts, all the speakers. Thank you very much indeed for your commitment and your help. And it was a very interesting webinar. We had more than 100 participants during the whole webinar, which is a good result for the first one. So I remind you that the next one will be in September. You will be advised about the topic and the exact date of the next webinar. Thank you again, and have a nice evening, and see you soon. Bye.